all of you. I hope all of you are still attentive after such a post, lunch session. As Dr. Anil Mehta just said that, this academic feast is more tastier than, the food. At the outset, I would like to thank Dr. Anil Mehta and Educon for having us here. I bring greetings from Nanavati Max. I have been asked to talk on, hepatitis B, hepatitis C update. Many speakers must have spoken to you about this topic many a times. So this is like a old wine in new bottle. There is nothing new like Dr. Bhavesh mentioned in his previous talk. But in next 15-20 minutes, I would like to talk to you about how I approach my patients with hepatitis B and C and what is new. So without wasting much time, let's begin. So as we all know that hepatitis B and C, they have a huge global burden. And particularly in India, 40 millions of the hepatitis B patients, and there are 8 to 10 millions hepatitis C patients are there. And if you look at the graph, the lethal trio, tuberculosis, HIV, and malaria is going down, but there is a steep rise in hepatitis-related mortality. So this is still a major killer even now. So I would like to start with this case, which is a real-life case. 54-year male, diagnosed case of chronic hepatitis B since 12 years, and he has been started on treatment outside from a general practitioner. Initially, he was on lamivudine, which later on was converted to adefovir, and since last 6 years, he is on tenofovir. Patient is asymptomatic. He is very, very educated patient. He is on regular follow-up. There are no complications. Though there is a family history of SCC, his father was suffering from hepatitis B and he died because of hepatoma. So he was a little concerned. But since 6 years, he was, I think since 4 years, he was following with me. And each time I was just asking him to do test, and LFT is normal, DNA not detectable, liver function test normal. So he was kind of pissed off, even sonography was normal. And we did his fibroscan. His fibroscan was, LSM was 8.9. So with this, his question was, since these many years, almost 8 years, he's hepatitis B negative. So can he stop treatment? So can I just ask all of you, how many of you, tell this patient that he can stop treatment? Just raise your hands. So none of. Let us see the evidence to that. Why not? So this is, all of us, we know that major mode of transmission, hepatitis B, is horizontal. And in 20-30% of the cases, we don't know the transmission. So whenever we see a patient who is Hep B positive, this is how our approach should be. We should look for that. We should ask these 3 questions. Is there any viral replication, which will be determined by hepatitis B viral load and the activity like E antigen, anti-E antibody? Then the second question should be, is there any liver inflammation, which will be denoted by deranged liver function test, transaminitis, or sonography showing evidences for either chronic liver disease or increased fibrosis, or a fibroscan showing increased stiffness. And the third point is whether he is a treatment candidate or not. So these should be the 3 questions that we should be asking. Same thing. So all of us, we know that SBCG indicate that the presence of virus in the body. E antigen indicates the replicative state. Anti-E indicates the non-replicative state. IgM anti-core total, it is indicative of recent infection. IgG core total is indicative of past infection. Anti-HBs is immunity against hepatitis B. And DNA tells us about the viral replication or viral load. So this is an important slide, I would say, because the old nomenclature has been replaced with the new nomenclature. Earlier, we are familiar with the terms like immune tolerant phase, then the immune reactive phase, then the carrier state, and the flare reactivation and the control. So now, as per the new guidelines, hepatitis B, especially the chronic hepatitis B, is divided into 4 stages, E negative and E positive. Amongst E negative, there is a chronic hepatitis B infection and chronic hepatitis. When I say hepatitis E, that is HBE positive infection, that means there is just a high. Okay, so it's just a high levels of DNA, but normal ALT, so normal liver function test, and no inflammation whatsoever, normal fibroscan. So this is just a E positive HBV infection. When I say hepatitis, that means there is an inflammation of liver, which will be indicated by transaminitis. So E positive, E negative. Similarly, E negative will have just infection when there is a no inflammation and normal LFT, and when there is a abnormal transaminitis, this will be termed as a E negative chronic hepatitis. Understood? So E positive, E negative, chronic hepatitis B infection and hepatitis. So we all know that when we treat hepatitis B, this is what is our aim, that it controls or cures cirrhosis. Sometimes it reverses fibrosis or cirrhosis. It also reverses the liver decompensations, reduces risk of hepatocellular carcinoma, reduces liver-related mortality, and overall it improves survival. So now coming to, whom should we treat? What are the treatment guidelines? So these are the current guidelines. There are various bodies like American Association, European Association, Asia Pacific, and INACEL. And there are various recommendation that E positive, this level of ALT, this level of DNA, and this level of inflammation. So instead of that, what I think that instead of going into the guidelines, we should think about when to start. So these are the simple parameters that you should think whenever you are thinking about treating this patient. So life-threatening liver disease, high risk of SCC or cirrhosis, higher level of DNA, especially DNA more than 5 log to 6 logs, and evidence of inflammations in the form of transaminitis, low thresholds in the older patients or family history of cirrhosis or hepatitis B. So this should be the common indicator that we can use in a common clinical practice rather than going for the guidelines. So we all know that there are approved guidelines, interferons and the nucleosides, but which amongst these should be? So all three, that is entecavir, tenofovir, and TAF, should be the first line of agent. All of them, they have a similar efficacy. Let us see which we should use. So before that, we all know that interferon is a conventional, we used to treat with the patients in earlier 1980s. All of you must have, in fact, many of you must have used this. Finite duration, more durable response, less chances of resistance. But the downside is that it is expensive, associated with the many side effects, and many patients, they are not very confident with the injections. Then after the advent of oral drugs, this changed the treatment of hepatitis B, and the oral drugs, they are very easy to administer. They have a negligible side effects, more threshold for resistance, but the problem is that they have to continue lifelong. And there is a risk, theoretical risk of resistance, which is very, very less with the available newer thing. So this is how we should approach when we decided to treat these patients with hepatitis B. So if patients without any comorbidities, we can use any of the three agents, entecavir, TAF, or tenofovir. If suppose elderly, especially age more than 60 years, bone disease, and the renal involvement, the treatment of choice will be either TAF or entecavir or TAF. And when there is a prior exposure of other antivirus, especially the lamivudine, or in cases of HIV, the treatment of choice should be TAF or TDF. Pregnancy, TDF, that is tenofovir, is the only approved treatment as of now. There are various trials where TAF has been considered, but so far the safety data is limited. So pregnancy, TAF without comorbidities, any of the agents, with bone disease and elderly or renal involvement, entecavir and TAF, and the TDF and TAF when there are previous exposures of lamivudine. How long? That we will come to know. Okay. So why to push for new therapies? So why there is a need for new therapies? as we know that there is a limitations of current oral therapies because treatment is long term and we can just control virus. We cannot cure virus like hepatitis C. So unlike hepatitis C, which can be cured with available drugs, which we will see in the upcoming slides, but we can only control hepatitis B because hepatitis B is integrated into the nucleus because of the development of CCC, that is a covalently circular DNA. So because of which that is integrated into the nucleus and DNA, because of which we can never, as of now, cure hepatitis B. We can just control hepatitis B. So, and even if we treat hepatitis B, DNA may be negative, but hepatitis B still, surface antigen is still positive. So that is sort of stigma that HBsAg positive. And on the other hand, hepatitis C, which once upon a time was considered as a deadly disease, nowadays it is easily treatable. So this success, because of which there is a need to push newer therapies of hepatitis B. So there has been a changing paradigm shift in the treatment of hepatitis B. Earlier, we were talking about control, so suppressive therapy. So our aim used to be control DNA, try to get HBe anti-conversion, that is E negative and anti-E positive, and hope for HBsAg loss or development of anti-HBs. But nowadays, we are aiming for functional cure, which means that HBsAg negative and undetectable HBB DNA. So this is the next priority that we are talking of. And what is desirable or what we want is to have this complete cure where we should get rid of not only virus, but the cccDNA virus, which is a reservoir of virus in the nucleus. So once we can achieve this virus can be completely cured. So are we close to it? No. Why? Because, as I said, there are barriers to the functional cure of hepatitis B because of this cccDNA, because of which there is a weak immunity response and the burden of the virus is very, very high. So there are various drugs, right from the entry of virus till the virus replication, integration, and the secretion of virus are in the pipeline. As I said, this is the biggest barrier, cccDNA, because of the long half-life, integration, and only interferon is active against it. So there is a research into the use of interferon. Probably in few years, we might have something that can cure us when we use interferon. Again, these are the drugs in the pipeline. So now coming to your question, sir, how long we should continue? Now coming back to case, before that, when we should stop this drug. So in non-cirrhotics and cirrhotics you should never stop. So compensated cirrhosis, decompensated cirrhosis. Once the cirrhosis is there is no question of stopping antiviral. So you have to continue it.
2 minutes.
So when there are non-cirrhotics, only when E negative, you can consider of stopping hepatitis B antivirals, only if there is a E seroconversion and additional 1 year to 2 years of consolidation. So coming to our case, I'll just run through this in the interest of time. So our patient is seroconverted and he wants to stop therapy. We should not stop because of there is a family history of SCC and his fibroscan was 8.9. So despite being seroconverted, we still have to continue. Now coming to hepatitis C. So briefly, this is an asymptomatic 43-year female, incidentally detected hepatitis C, 2 million of viral load, normal LFT, no fibrosis. Should we treat this patient or not? How many of you will treat just HCV RNA positive patient? Only 2, 3. Okay. So just to tell you that why to treat hepatitis C. So if you don't treat, the all-cause mortality, including liver-related mortality, will be high in hep C patients. Our aim should be to achieve SVR, that is sustained virological response. And this is the natural history of hepatitis C. Most of the infection will be converted into chronic infection. So if the RNA is positive, we should treat all the hepatitis C. Otherwise, there is a high likelihood of liver cirrhosis and the cancer. Again, this is a natural history of Hep C. This is how the drug evolved. Right now, we are living in the era where we can use directly acting antivirals. These are the combinations available. All of them are very well tolerated, very few side effects. And earlier, what we considered as a difficult to treat, now easily treatable with the available newer medications. So there is nothing that we can think of that this population is untreated. And these are the guidelines. Even if we treat hepatitis C, we should follow them every 6 monthly with sonography to detect them for the development of SCC. And when to refer when there is a decompensated CLD, end-stage liver disease, or DA failure. So which is hardly a 2 to 3 population. Even there is a DA failure. So this is how we just published paper. We can be treated even with the combination of the therapy. Again, important thing in treatment of hepatitis C is that never combine DAs with PPIs. If you combine them with PPIs, their efficacy will go down. So omit PPIs whenever you are considering. Another thing to consider is drug-drug interactions. Okay, especially amiodarone with sofosbuvir, because most of them will have a heart conditions to begin with. Then there is a hepdruginteraction.org. You can go there and you can see all the interactions. But commonly used drugs like rifampicin, digoxin, and statins, you should be aware of. So this is how the treatment of hepatitis C as of now. So treatment naive, non-cirrhotic patients, we can consider DAs, especially the SOF, velpatasib, and SOF dacla. They have an equal efficacy of more than 95% of SVR. And if the cirrhotic or treatment experience or decompensated, the combination plus ribavirin for extended period, that is 6 weeks. So this is how now we stand as per as the hepatitis C treatment is considered. So I think with this, I would like to end my session. Thank you for your patient hearing. Thank you.
Good afternoon, everybody. Well, I am Dr. HEMANT TONGAONKAR. I am the Senior Director of Urologic and Gynecologic Oncology and also Head of Surgical Oncology at Nanavati Max Institute of Cancer Care. We started this about a year ago, and we have different specialists looking after different subspecialties of cancer, and I look after only urological and gynecological cancers, the same which I used to do when I was in Tata Hospital. No? Is that better? Yeah. I'm going to speak today about advanced ovarian cancer. As we know, ovarian cancer is the most lethal gynecological cancer. You know, it's the third commonest among women in India after breast cancer and cervix cancer, but it's one of the most rapidly increasing cancers in women. But what is even more important is that it has the highest disease-related mortality amongst all gynecological malignancies. And this is because of two reasons. Because ovarian cancers phenotypically are extremely aggressive. And secondly, 70% are diagnosed in advanced stages across the world. Need not be only in India, but the same stands true even in Europe or in the US. So obviously these are difficult to treat and difficult to salvage because most are diagnosed in advanced stages. Cure rates are good in the early stage, but extremely poor in the advanced stages, and this remained unchanged till about 15 years ago. In the last 15 years, we have been doing something extra, something more aggressive, more radical, by which we have been able to change these poor survival figures into some which are at least much better, more acceptable. It needs an aggressive therapeutic approach. If you ask anybody, how do you manage ovarian cancer? Surgery and chemotherapy. Not true. You require the best surgery and best chemotherapy if you want to cure ovarian cancer. You've got to do everything right every step of the way if you ever want to cure an ovarian cancer. And that's what we are aiming for. Now, why are they diagnosed very late? It's basically because ovarian cancer does not have any symptoms in the early stages, and even if they do develop symptoms, there are very subtle variations of the normal physiology of a woman. There will be just mild back pain or abdominal pain, some bloating, indigestion, some urinary problems, bowel problems, something which will be unnoticed, not only by the patient but also by the doctor. So that is why I want all of you to be aware that if any of these symptoms are repetitive or persistent, then one must at least get an ultrasound of the abdomen and pelvis done. And more often than not, you will find that this lady has some ovarian problem. So these are very subtle symptoms, and we should really have a high index of suspicion if you want to treat or diagnose this cancer early. How do you investigate? Most of them present in an adnexal mass, and apart from clinical examination, which is extremely important, abdomen, pelvis, and breast, one needs to do certain investigations, and those are the tumor markers and imaging. These are the two most important ones. Tumor markers, as we know, that CA125 in younger patients, alpha-fetoprotein, beta-HCG, and imaging is usually a CT scan. Do we really need to have a PET scan? Well, PET scan will give you some idea about extra-abdominal disease, inguinal nodes, axillary nodes, any breast lump. Yes, in advanced ovarian cancer, one must get a PET scan done whenever it is feasible, financially feasible. But otherwise, a good CT scan is what is necessary. Also, some of the ovarian cancers are secondary. They come from breast or GI cancers, and that is why even these other investigations like mammography, upper and lower GI endoscopy, etc., may be necessary in some patients. We should always get a CEA done along with CA125. If CEA is high, or the CA125 to CEA ratio is less than 4, then one must definitely get an upper and GI endoscopy done. And a CT scan actually gives you a very good picture. This is not working, can you give me? Oh, yeah.
On LED, this doesn't work. So only to change the slide. There is no pointer.
Okay, all right. So you can see here with the arrows that you can get the idea about the paralytic nodes, the omental caking, large peritoneal deposits. You know, ovarian cancer spreads in the form of small nodules, which are over the peritoneum, over the bowel, and also plaques, something which may not be seen very well with a CT, and that's where PET scan becomes useful. So the best imaging also has an accuracy of 70 to 75%, only not 100%, and that one must be aware of. What we do, I always sit with my radiologist, last 15 years I've done that, and see every scan together. And it gives you a very good idea about the resectability of the mass. Now, if you want to know whether the mass or the disease, entire disease is resectable or not, there are two ways. One is the traditional way. You can go to a roadside astrologer, ask the parrot to pick up. Or you could do something which is more scientific and do something like a staging or a diagnostic laparoscopy. Have a look inside, and at least you will save an unnecessary laparotomy. So find out the resectability when you're dealing with advanced ovarian cancer. And of course, surgery is the mainstay of treatment. Biopsy is not recommended for early stages of disease, but if the disease has already widespread, there is no harm in doing a biopsy. But if you're going to operate upfront, biopsy is unnecessary. Only if you're going to treat the patient with chemotherapy upfront, then a biopsy may be done. Otherwise, you just excise the mass and do a frozen section. So how do we treat aggressive surgery? With the aim of, this is extremely important, with the aim of macroscopically complete resection of all visible tumor. That means you should have no visible and palpable disease at the end of your surgery, and then treat with platinum-based chemotherapy. Look at what has happened from 1960 to 2000. With better chemotherapy drugs, response to therapy increased from 25% to 80%, but the survival did not change. So that means chemotherapy was better, but surgery was not. And it has been seen by a number of publications over the years that the amount of residual disease that you leave behind is the most important factor that impacts outcome. Now, what is cytoreductive surgery? Cytoreductive surgery means you reduce the cell volume to a minimum so that chemotherapy can act better. Now, in all cancers, you are told, go wide, go wide. Here, you can't go wide. You just remove as much as possible, and you hope that you are able to remove the entire disease, because if you see, patients who have no microscopic disease have a median overall survival of 40 to 60 months. Those who have a residual disease of just less than 1 centimeter, their survival goes down significantly. And same thing, you can see there are so many trials which have shown that there is a distinct difference in survival in patients who have no residual disease at the end of your surgery, and even if you leave 0.5 centimeters behind, it significantly reduces the survival rates. As you can see, there are multiple centers which have shown the same. 0 survival is 62 months. Any residual, 20 months. So there's so much of drop in survival even if you leave behind 0.5 centimeters. Once that was realized, we agreed that we need to do something more. Normally, we are told when we were students, surgical treatment is THBSO omentectomy. That's it. And anything on the peritoneum, on the bowel, on the diaphragm was considered beyond the reach of curative surgery. Well, once we realized this, that to remove that last 0.5 centimeters or 1 centimeters is very important, we started doing many more procedures, and these are called ultra-radical cytoreductive surgery, which we specialize in. There are very few centers in the world which specialize in this, and we are one of the very few centers which offer this regularly. Ours is probably one of the largest series in the world, if not the largest single center series doing this. So, apart from THBSO, omentectomy, pelvic and para-aortic lymphadenectomy, we do a routine total peritoneectomy, bowel resections, 1, 2, sometimes even 3. Dr. Nagarajan is here. He is a GI and hepatobiliary surgeon. It's always a teamwork, and the surgeries can last up to 8 to 11 hours. Liver resections, splenectomy, distal pancreatectomy, diaphragmatic resections, urological tract resections, and the extra-abdominal lymph node dissections. Now, when you do all this, it takes 8 hours, 10 hours, 11 hours, but if it's being done by a specialized team, and if it's being supported by a good ICU infrastructure, then all this can be very safely done. R0. Now, of course, it is called CC0. So, in the more scientific terms. But what we do, we start from the pelvis. We remove the ovaries and the uterus, do pelvic lymphadenectomy, remove the entire peritoneum from the pelvis, including the bladder peritoneum. We move into the mid-abdomen, remove the peritoneum there, remove all the paracolic peritoneum from both the sides, then reach the diaphragm, we do both diaphragmatic peritoneectomy. Sometimes you have to excise the peritoneum if there is gross disease and put a patch. Then we do the retroperitoneal lymphadenectomy, liver resections on the left side, sometimes the omentum, if it's gone to the spleen, then splenectomy. It's a long procedure, but it's a very safe procedure in experienced hands. Actually, we have just lost one patient in the last 11 years, and that too very, very recently. Till now, we had not lost a single patient to this. So omentectomy, again, you can see that there's gross disease on the omentum. I have a choice. I can just remain very close to the bowel and remove the disease, but leave behind microscopic disease there, or I can do a complete transverse colectomy and remove the entire disease. Do the latter. Now, this is the kind of complete lymphadenectomy from the renal hilum right down to the bifurcation of common iliacs, and then the complete pelvic lymphadenectomy. That is the standard. Now, sometimes we have large masses like this in the retroperitoneum, and we need to remove them very, very carefully. And this really requires a lot of experience. Bowel resection, as I said, is required in almost 40 to 50% of patients. And only if you have prepared the patient's bowel well, then only 2.7% of our patients have needed a stoma. Most of the times we are able to close and not have a bowel leak after that. It is very important to counsel the patient before, tell her that she may need a stoma, and then only you can go ahead and do this surgery. This is the diaphragm, which has been stripped completely. You can see there are a lot of disease here. You can see the bare muscle in the middle. This thing, sometimes you have to excise and put a patch there. So, and nearly 40 to 70% of patients of ovarian cancer, advanced ovarian cancer, have disease on the diaphragm. This is the most common cause of so-called inoperability across the world. And this is something which can be very easily done. It doesn't take much time, doesn't take much expertise, and this is something which has really transformed, because from here the disease goes into the chest. Resection of all peritoneal disease. As I said, parenchymal liver and splenic metastases are not very common. But again, we have the largest series of parenchymal liver metastasis treated with hepatic resections, again, Dr. Nagarajan. And we've been doing this very regularly. Similarly, sometimes a partial cystectomy or even ureteric reimplantations may be necessary. Now, this is something, as I told you, very unique of ovarian cancer. Tiny nodules everywhere. I can easily give in to temptation. It's too much of disease. Just let it go. It may take 2 hours, but you need to remove every nodule that is there. Okay? That is extremely important. And why is it important? As I showed you, that now with these ultra-radical procedures, the survivals have gone up to 40 to 45%. It's a huge jump. In ovarian cancer, in breast cancer, we are struggling to get 1 and 2% improvement. This doubled the survival with ultra-radical surgeries. And now most centers who do this achieve a good cytoreduction in more than 90% of patients. You can see even the timelines. If you come to 2004 onwards, the survivals have improved, and that's basically because we have been able to remove all the disease. Now there are people say, oh, this has a very bad tumor biology. So even if I remove the patient, is going to come back with disease in 6 months. Why should I do this? Well, it has been shown very, very conclusively in numerous trials, numerous centers across the world, that you can improve the survivals very, very significantly. Just to tell you, there was a patient of mine, we operated for 8 hours, she came back with disease within a year. We did a secondary cytoreductive surgery, again lasting for 6.5 years. She was given, fortunately she had some molecular mutation, genetic mutation, which was positive, so we gave her pembrolizumab. Patient is not only well, she went and represented India in Mrs. World. So, you can have that kind of lifestyle. Patients are absolutely fine.
2 minutes.
Yeah. So, what I want to tell you is that as a surgeon, as a gynae-oncologist, I have a very small window of opportunity during this surgery wherein my actions will decide whether the patient is going to live long or patient is going to die early. So no patient should be denied this opportunity, because every patient has a full right to live. And that is why, please, such patients, don't look at them in a nihilistic way. You should be very, very proactive and give them the best that they deserve. And this is our own series, 592 patients done till now. You can see primary, post-chemo surgery, secondary surgery with a complete cytoreduction rate of 89%. And you can see all these procedures which have been done. So it's a big study that we have. Only when you have disease like this, which obviously cannot be removed completely by the wildest stretch of imagination, even if you do a complete bowel excision, still you can't remove this disease, only then you can give chemotherapy. Nowadays it's a fashion. Ovarian cancer, give chemotherapy, reduce the disease, and anybody can operate. No, that's not true. The disease may come down, but what remains after chemotherapy is predominantly a burden of chemo-resistant cells. Chemosensitive cells have died with chemotherapy. So here, you may not be able to make out the difference between normal area and a disease area. And there is more chance of leaving disease behind. So unless it is absolutely essential, only then do neoadjuvant chemotherapy and then do surgery after 3 cycles. But otherwise, primary surgery first. Morbidity, mortality, as I said, there is a certain amount of morbidity. Definitely, if I say I don't have any complications, I'll be lying. There are complications that do happen, but they're predictable and they're easily manageable. You need a team. And most of the patients remain in the ICU for a day or maximum 2 days, not longer than that. So the question is, who should operate on ovarian cancer? It's an evidence-based review. I'm not saying I'm saying any trained gynae-oncologist or a team of gynae-oncologists should operate, because that gives the best chance of staging and best chance of treatment to these patients. So best chance of survival is in the hands of gynae-oncologist. Lastly, just wanted to show you, what about laparoscopy? There are many people who do laparoscopy for ovarian cancer. But in the words of Ganesh, who is the foremost laparoscopic surgeon in the world, doing laparoscopic surgery for ovarian cancer amounts to negligence. That's what he says. Early stage ovarian cancer, yes, you may do. Advanced stage ovarian cancer, no laparoscopy, you'll land up with port site recurrences like this. In select patients, by all means you can do, but the kind of procedures which are done laparoscopically, aspiration, morcellation, all cause spillage. And once there is spillage, the disease spreads very rapidly. So that's not to be done.
Please conclude.
So, yeah, last slide. Yeah. So what is important, what is responsible for these improved results? Training, experience, willingness and effort, aggressive cytoreduction, intensive chemotherapy, and reduction of complications. And with all this, people say the central point is most important, the tumor biology. I can't measure tumor biology, can you? This tumor biology is 3 or tumor biology is X. I can't. I say it's not tumor biology, it's the surgeon biology which is very important. And you can easily reverse any tumor biology with good surgery. Lastly, to quote Shakespeare, diseases desperate born are treated with desperate measures or none at all. If you want to treat with full confidence, otherwise don't treat, send to somebody else who will do a good job. Thank you so much.
Presenting our token of appreciation for Dr. Hemant. Thank you, sir, for a wonderful update on cancer management.
There is one small study in interval surgery where there is a marginal difference, but that study has been criticized on numerous counts. So today, except for mucinous tumors or pseudomyxoma, there is no indication to do HIPEC. I know that many people who do it. I also have HIPEC available with me. But HIPEC, there is absolutely no evidence that there is benefit with HIPEC. Most of the studies are retrospective or prospective studies which are non-randomized. So there is a selection of patients. You can't draw any conclusions from that.
So good evening, good afternoon everyone, and with an exciting match going on, I think very nice to see such a huge audience here. And special thanks to Dr. Mehta for organizing such a great conference and having us here. So over the next 15-20 minutes, we'll just look at how robotic surgery has evolved in GI and HPB oncosurgery, pros and cons, how do we select out, what's the exact evidence today, and how we go ahead. So over the last decade, we've got a lot of such papers talking about lap versus open, minimal access surgery for colorectal cancers, pancreatic cancers, even liver tumors. So how all this has evolved over the last 2 decades? So if we look at how oncology surgery has progressed, in the early 60s, 70s, the whole aim was to just somehow send the patient home alive. Then came a stage where people started doing radical resections and more radical resections, trying to cure cancers, and often not very successful at that. Then came in a lot of chemotherapy, radiation, targeted therapy to help the surgeons, and then the overall outcome started improving. And then in the last couple of decades, we saw that, okay, now we are able to cure these cancers, we're able to send home a lot of patients, and they're all able to live a long life. So then we started looking at quality of life. We started looking at how are we able to get these patients home earlier, how are we going to rehabilitate them, get them back to work earlier, and that's where minimal access surgery came in. A lot of laparoscopy came in initially for colorectal cancers, and then came in robotics. So difference compared to maybe 10 years back, where hardly ever we would see an early stage tumor. Today we are still seeing around 10% of our patients as T1 or T2 tumors, which is very encouraging, especially in urban India today with more and more screening, more and more patients getting scans for whatever reasons, and then suddenly there's a tumor which is picked up, and those are the ones where often we are able to give them minimal access surgery. Many of them, as I said, small tumors, early lesions. It's very useful for young patients. Many of them have busy lifestyles. They want to get back to work early. They want to get back to swimming, to gymming and all of that earlier. They don't want a big cut. That's where laparoscopy and minimal access surgery has come in a big way. Surprisingly, it's also helped older patients because old patients with a big incision right from the xiphisternum to the pubis, sometimes post-operatively they'll be in the ICU for a couple of days more. They don't breathe very well. Basal atelectasis in the lungs, tend to develop pneumonias. In those patients, older patients, if we are able to do a robotic surgery, we are able to get them off the ICU. Often we don't send them to the ICU at all. And faster recovery actually therefore means a lot to both young and old patients. There's a lot of, whenever people ask me why robotic, why not laparoscopy? I mean, finally it's the same small incisions. So yes, of course you can communicate with a landline, but you do use a mobile phone these days. So it's pretty similar. However, it is important to understand that open surgery will always have a role. We have to tailor the surgery to the tumor, to the patient, to the other comorbidities that the patient has. That's very important. For every one patient that we see who is amenable to a robotic surgery, you'll have 9 patients who will have tumors still coming like this, and these will not be treated with robotics or laparoscopy. These will still have to be done, will still have to be done with open surgery. What are the benefits of robotics over laparoscopy? With the best of laparoscopic cameras today, we are able to get a magnification of 2 or sometimes 3x. Here we are, with robotics, we get a 10 times magnification. Now how does that help? When we have a 10 times magnification, we are able to see blood vessels more clearly. We are able to see smaller vessels more clearly. We are able to pick each lymph node out. We are able to identify nerves, especially in pelvic surgeries and colorectal cancers. Nerve sparing is very important for the quality of life. The nerves which go down control the bladder, and they also control sexual functions. So patients often with, when we do robotics, we're able to see these nerves so clearly that often we are able to do a good nerve sparing clearance in these patients. And there's a significantly higher chance that this patient is going to have better bladder functions and sexual functions, even after a very, very low anterior resection for CA rectum. 2D versus 3D. Laparoscopy is always 2D. Now, of course, there's 3D laparoscopy, but robotics is an excellent 3-dimensional vision, and that actually helps because it mimics open surgery. It gives you the feel of an open surgery. It has 7 degrees of motion, like open surgery. Laparoscopy has only 2 degrees of motion. So, if you compare, the ease of doing a robotic surgery for an open surgeon is much better. And hence, a lot of oncosurgeons today have adopted to robotic surgery much faster than laparoscopy. Ergonomics for the surgeon. This works much better because the surgeon is comfortably sitting at a console and operating with the patient in the same operating theater. What that facilitates is that if it's a 6 or 7 hour surgery, it's very comfortable because we are sitting, it's ergonomically much better as compared to laparoscopy where we have shoulders. Today a lot of laparoscopic surgeons have to, after 10 years of practice, have to rush to the orthopedic surgeon because they either have a disc issue at the cervical problem or shoulder issues. It's very common among laparoscopic surgeons. So ergonomically, it's a blessing for the surgeon. Look at the learning curves. Very interesting study here, which looked at learning curves in terms comparing robotic and laparoscopy. So much faster adoption. So it's much easier. I think the success of any technology is its adaptability. If more surgeons are able to adapt and do a particular surgery successfully with a particular instrument, rather than just one great surgeon doing a fantastic job laparoscopically. I think that's a big plus with robotics. More easily learnable, more easily doable, hence its adaptability is much better. Tremor elimination, so the older you get, sometimes surgeons could start getting tremors, but the robot doesn't get tremors. So the complete control of the surgery is with the surgeon, but it eliminates tremors from the surgeon's hands completely. Very interesting. This is the oldest practicing surgeon in the world. She's 92 in the UK, and I think she'd find robotics as a blessing. Suturing is much easier with robotics. It's got much better precision because of the three-dimensional motion, because of the wrist movement in the instruments. The robot has a very interesting feature where we have a wrist movement which is similar to the human wrist, which cannot be mimicked in laparoscopy. And that's why it's so much easier to suture, and that's why more complex surgeries can be done robotically. We've got the XI system at Nanavati, which is the best possible robot, which is the latest robot in the world. And we've got this ICG function, which shows us vascularity before we join the loops of intestine. So when we do a colorectal anastomosis, this is an ICG feature. Our anesthetist just gives a loading dose of ICG, and in 3 minutes we are able to just click off a button at my console, and I'm able to see this. And that shows the vascularity of the two ends of bowel. So when we know that it's got good vascularity, we are able to join it. The leak rates are much lesser. Let's look at some data. Overall, this is a meta-analysis, looked at large number of patients, more than 1 lakh, 73 studies. Overall, when they compared colorectal robotic to colorectal laparoscopic, lesser conversion, lesser overall mortality, lesser wound infection, shorter hospital stay, lesser blood loss. So a lot of advantages when it came to robotics. This is again a similar meta-analysis which compared liver resections, robotic versus lap. And again, similar findings. Of course, the time for robotics was a little more, but significantly lesser blood loss in the robotic arm. And overall, the advantage in robotics is there's a lesser conversion rate to open surgery, and that is a big plus. Parenchymal transection, of course, in liver resections, we don't have a robotic CUSA. That's one of the negatives, but we are able to manage quite well, and I have a video of that. Maybe we can just run through that in some time. This is some of our data where we looked at all our colorectal robotic surgeries, and we found a significantly less, overall, our mean hospital admission stay and discharge time was 3 days after a major robotic colorectal surgery. Return to bowel function was the next day in most patients. So we operate and the next day the patient has passed motions, and we are actually ready to send them the day after. But most patients are so uncomfortable going home. In India, people don't want to go home early, so we tend to keep them for another day, but yet we are able to send them by day 3. Lymph node yield is similar, pain score is significantly lesser, and our margin negativity rate is absolutely similar to our open surgeries. We've got a lot of newer gadgets with robotics today, and we've used all of them in our cases. This is the robotic harmonic has been around for a long time, but this is the robotic vessel sealer, which has helped significantly, and these are the Surform staplers, which we've again used for our rectal anastomosis. Of course, finance is a constraint, but the prices are coming down. I think they're doing their bit to try and cut down the costs. And compared to a couple of years back, I think today it's definitely become a bit cheaper. And we do keep expecting that it'll keep coming down. But overall, it's probably the difference around 1 lakh, 1.5 lakh, which I think most patients really don't crib about because they go home 2-3 days early. So it's actually not a very big difference. A lot of innovations in the future, smaller ports. The whole, now probably the robot may just be a table-mounted robot in the future. A lot of artificial studies going on in AI with robotics. That will be exciting. Today already some, in France, there are some studies on artificial intelligence guiding the liver resections, and that's very exciting.
Minutes.
And a lot of, yeah. So that's as far as, so in the next 2 minutes, let me just quickly try and show you a video to show you how this works. Can you just get back to So it's just to show you, it's one of our videos of a robotic liver resection, just to show you, you know, the kind of imaging and kind of clarity that we get. Just click on the movie. No, there's, so this was, no, there's no volume. So you can see this is 10x magnification that I spoke to you about. This is a small tumor in the liver, in the left lobe. So we're doing a left hepatectomy here. And you can see the clarity with, you know, with which we are able to dissect out every single small vessel. That's, you know, usually liver surgeries are expected to be, you know, with a lot of blood loss. We probably would have lost around 25-30 ml of blood in the surgery. So, you know, and that's thanks to the kind of clarity that we get with robotics. And you can see when you can see everything with such clarity, you are obviously able to dissect out each vessel separately. And, you know, there obviously the blood loss comes down. One of the advantages in liver surgery is also when we have a pneumoperitoneum, we have the pressure, and that pressure actually reduces the bleeding. So, I wouldn't, you know, I just wanted to show you so that, you know, you get a little bit of an idea about how this surgery works, and I think I'll leave it at that, and I'll be happy to take any questions if there are. Thank you.
Thank you, Dr. Ganesh. That was a wonderful presentation, and your videos and all were very mesmerizing. May I request Dr. Anil Mehta to please give him a token of appreciation from our side while Dr. Rahul loads his presentation on recent advances in interventional cardiology.
You can click that.
Thank you, Dr. Ganesh.
Yeah, so good afternoon, everyone. And I think three or four important things which we learned from last few lectures is that you know, we are looking for more precise, more safer treatment options, shorter hospital stay, shorter ICU stay, as well as we don't want any patient to be excluded. You know, so therefore we should, like one of the speakers said, that because sometimes we are not aware about the procedures, we deny treatment to the patient. We don't tell them that, you know, we don't tell them that this treatment exists. So today I'm going to look into, tell you some recent advances in interventional cardiology, which a lot of you people know about it, but we will see how we can, you know, understand. So interventional cardiology has been a tremendous innovation in the treatment in all form of heart disease, whether it is hypertension management, valve disease management, you know, complex coronary work, cardiomyopathies, rhythm issues, something, you know, some diseases which were previously said that it cannot be treated and patient was just left on their fate, just on whatever medically we could do to them. We have tools like FFR, IFR, where there is a lot of confusion. Some people say, you know, this patient requires an angioplasty. Some say it's a bypass case. Some people say medically it can be managed. We have tools like that. Then previously declared unfit for any treatment, extremely high-risk patients can be treated with safety, precision, and confidence. And we will go through some case discussions. I think there were some lectures in the morning. I don't know what they discussed, but if they have discussed, I'll just skip through those. So let's go to the case number one. Now, 56-year-old gentleman, uncontrolled hypertensive since many years, BP persistently more than 180, 100, and he has tried. You have given him everything. You've given him ARB, CCB, diuretics, beta blocker, centrally acting drugs, alpha blockers. And what we notice, we get these kind of patients, about 10% of our patients will fall into this category, where whatever you give, either they are not controlled or they develop side effects. So they would develop side effect electrolyte imbalances with diuretics, pedal edema with calcium channel blocker. So what should be the approach? So you have a case of resistant hypertension, which you may see in your day-to-day clinical practice. So approach is, first you should rule out non-compliance. You will be surprised that a lot of these patients are actually not taking their medications regularly. So please rule out non-compliance. In fact, I have admitted patients and given them treatment because I suspected non-compliance to see whether they are getting under control. So BP is still high. You know, you rule out white coat effect. You will see patients. I had a young boy, BP 180 by 100, pulse rate 123 in the clinic. Now you'll be not wanting this patient to send him like this. But I asked him to do an ABPM because you get some clue. There were no target organ damage, no LVH, and no ECG changes of LVH. So I asked him to do an ABPM, BP 120/80, pulse rate 70. So you can get these kind of scenarios where BPs are extremely high. So please rule out white coat effect. The Indian heart study showed that about 24% of Indians have white coat hypertension. So this is one thing which we need to remember. And then there are 10% of cases who would have secondary hypertension, thyroid, adrenal issues. So this patient, everything was coming okay. So what next? So next is something called as RDN. You should just know about this procedure. You should know about this procedure because it is renal denervation therapy. And this therapy is done for patients who are not controlled or developing side effect related to their BP medication. And it uses the radio frequency ablation. It's a very easy procedure to be done. Nothing, no complexities involved. Can be completed in about 45 minutes to an hour. So you do it just like an angiography. You go through the renal femoral artery. You reach the renal arteries. And you apply the radio frequency. So the renal, sorry, there are no this thing pointer, but the renal artery is covered, heavily covered by sympathetic nerves, and you tone down those sympathetic nerves. And that causes the reduction in the blood pressure in these patients. So this is the BP procedure, which we all should know for those patients who continue to be hypertensive despite taking all kind of medications or developing side effects. What happens is blood pressure is a silent killer. Most of the risk factor related to heart disease are silent killers. They don't produce symptoms. And it's a myth that if I have high blood pressure, I would have headache and all. Few percentage of people will get. But most of the people, they will not have any of these high blood pressure symptoms, but it is silently damaging the body. And therefore, hypertension is called as the silent killer. And this catheter, is very, interventionalists can do it in an hour's time, and patients' medications may reduce. Sometimes it gets completely eliminated if the BP was not very high. But and the symptom, this procedure is to be done only once, and it be an option for patients who are very hard to treat. This statistics is very important, that 1 in 3 adults have hypertension, 1 billion patient worldwide. India is already world capital of diabetes and hypertension. And there is a huge healthcare cost. And if you look at the risk reduction for a 10 millimeter fall in systolic blood pressure, these are the various advantages you will get in your patients, whether it is heart failure, stroke, coronary artery disease, heart failure. And these are statistics which are there from the Western world. The Indian statistics may be worse, that 8.2% of adults would give up 2 years of their lives to avoid taking one daily pill, and 50% patient becomes non-adherent to antihypertensive therapy within 1 year of initiating the therapy. So these are kind of the statistics which we have. So this is treatment which acts on the renal nerves, and therefore this modulation helps to control the blood pressure. So we'll go into the second case. If we have time, we will discuss about it. So this is one therapy. Now, I think the valve disease was discussed in detail, Dr. Anil. All the TAVI procedures and everything was discussed. So I'll not go into the detail, but these are all real-life case scenario. So I'll just tell you in very brief in 2 minutes. Any patient who has got like this TAVI procedure came for severe symptomatic aortic stenosis patients who were not amenable to surgery, like a patient like this, who could not undergo any kind of procedure because of comorbidities. They have COPDs, post-CABG, and it is very difficult for the surgeons to operate. Previously, these patients were denied any kind of treatment. They were just left for medical management. But with the advent, so first therapy was done by 2002 by Dr. Alan Crebier, and I'll show you the photo of Alan Crebier where I got trained. In the center, he is the person. And it's always a team approach. I think all this has been discussed. I will not go into the detail of the TAVI procedure. But this patient, so usually TAVI is now approved in patients who are even at lower age, like 65 plus. Previously it was all high risk patient. Now patients who are even at low risk of surgery, but they can undergo TAVI. But I just put in a case example of a 62-year. So the current guidelines says that patients who are more than 65 years of age, they are eligible for TAVI. But this patient who had low EF, 15% ejection fraction, he had a pacemaker in the past, moderate AR, severe AS, very low EF. He was referred for surgery in our center, but our team decided that we will do a TAVI. Just look at those who can read the echo. Just look at the contractility of the heart. It is hardly contracting. This patient could not walk even a few steps. And so these are just the picture of the echo. There is a AR. This is the leakage which is happening, the blue line which is going down. And this patient underwent the TAVI analysis. I will not go into the detail. Everything is done on the CT scan study, and this is how the picture happened. This is how you analyze the valve. This is how you release the valve. And this patient is doing very well. This was done in 2000, way back in 2019. This patient still continues to do well. His ejection fraction has improved to around 45%, and he can walk well. So these are the benefits. Did you hear about the trick valve? Okay, so TR has always got a stepmotherly treatment, you can say, because tricuspid regurgitation is often neglected, and people think that tricuspid regurgitation, nothing would happen. But a severe TR can lead to a lot of issues. So there was a patient with severe TR, had a pacemaker in the past, severe COPD, right heart failure symptoms. So we are talking about a lot of hepatobiliary thing. There could be one cardiac cirrhosis, something called as cardiac cirrhosis, where because of the tricuspid regurgitation, because of the backflow, there is a congestion in the liver and there is a right heart failure symptoms, and these patients do very bad if they are not treated. And therefore, there is a treatment for these kind of patients who have got severe TR and who are symptomatic, and they can be treated by something non-invasively, because surgery may be very high risk for these kind of patients, something called as trick valve. Surgical mortality can be as high as 9%. I will show you the demo of the thing. We will not go into the detail. The point of no return has to be avoided. If the patient reaches a point of no return, then doing anything is not possible. Surgery becomes costly. Even putting a trick valve may not be good to him. So we put two valves. One is in the SVC and one in the IVC. Finally, the SVC and IVC, they drain into the RA, and then the blood goes to the RV and then to the lungs. So there is a TR, so there would be impact through the IVC into the hepatic area, right-sided heart failure symptoms, and there would be all fluid overload everywhere. So I'll just go through this video. If we can go forward fast, I don't know whether. It's an interesting video where you will come to know about how the TR impacts. So this patient is having a severe TR. Now this is the SVC valve. You go, you deploy. This is the self-expanding valve, nitinol frame. So see how it is getting deployed. Once this is deployed, you go and deploy the SVC, the IVC valve. This is the IVC valve which is going, and all the impact of severe TR are mitigated. And these patients, they do really well after this has been implanted. So you should know about this therapy for patients who have got severe TR, right heart failure symptoms. I had a lady who must have shown to multiple doctors, recurrent admissions with tricuspid regurgitation, right-sided heart failure. Everybody said, you are very high risk for surgery, nothing can be done. But these are the patients who will get benefited. And they were surprised to know that this treatment existed and it was not discussed by anybody. The reason being because we are sometimes not aware. So these sessions are extremely important for all of us to understand that how we can help these patients. I'm not going into the mitra clip. Dr. Nehar must have discussed, but patients, mitra clip was not discussed? Okay. Okay, so just I will, very short, suppose somebody is with severe AR. EF is quite low, cardiomyopathy, DCMP. Now the surgeons do not dare touch these kind of patients, because if you do mitral valve replacement in these patients, after every mitral valve replacement, the EF goes down further, transiently, and these patients may not recover. So previously there was nothing. You just treat them medically, list them into a heart transplant, which is very difficult to do and difficult to get the heart also. It's not an easy procedure, and then there are, we all know about the transplant, immunotherapy and all. But now with mitra clip, you can actually clip the valve. So if you look at this, the mitral valve becomes into two valves. So you clip it in between. This was first discussed by Dr. Alfieri, and it was called as Alfieri stitch. And he found that if you just stitch in between the two valves, mitral valve, open heart, by open heart therapy, then the MR reduces significantly, it becomes negligible. This concept was then later on utilized by the interventional cardiologists, and Dr. Kar, Saibal Kar, is one of the foremost in this field, and he started doing mitral clips. And now we can help these kind of patients who are on heart transplant list. They can become better. They can, they will be so thankful. There are few patients from Mumbai where we did it in Chennai, because Chennai was the center. Apollo Chennai was one of the earlier center where I took some of my patients over there. We did the cases, and they are really thankful because they become so symptom-free and their ejection fraction starts improving. Similarly, those patients who have undergone previous tissue valve in the mitral area. So I had done a lady a few months back where the tissue valve was done about 15 years back. Now it had degenerated. The surgeon himself referred the case to us because he said repeat open heart surgery for this cachexia lady is going to be difficult. So we put a transcatheter valve. It is a TAVI valve only which you put upside down and you put it into this area, in the mitral area. And these patients, they do well. So these are all minimally invasive, 2 days hospital stay, and they are good to go.
2 minutes, please.
Yeah, okay. So I will discuss just 1 or 2 more cases. So this is MICRA. If you are aware about this procedure, this is a miniature capsule-sized pacemaker which is available and which can be implanted into patient's heart. No cuts, no leads, and this has also become very advanced. So it is like patient comes, you put a pacemaker, this MICRA, and then the discharge the same day. No incision. So this was done way back in 2017 by me at that time. And then, imaging is extremely important. Whenever we do an angiography, it's an external imager. Now, when you peek inside, you can do through IVUS and OCT, and it can be really beneficial. So what you see isn't always what you get. So what you are seeing on the angiography may not be the same thing. It may be something else. So this is the role of imaging. You can peek inside the vessel and you will be able to deal with very complex cases. So this was a very interesting case. Patient developed an MI after the surgery, and you see these ST elevations and multiple AVR and ST depressions in multiple lead. This indicates a left main situation. And look at the angio. This is a critical, almost patient is about to collapse. Cardiogenic shock. And now you are in a dilemma, how to treat these patients. So you do an imaging, you find out what, surgeons refuse to take up these kind of cases. I will show you, this is how the OCT looks like. And you can actually visualize what is happening inside, longitudinally as well as cross-sectionally in this view. And you can co-register. So this is the movement where the camera inside is showing. So external angiography. And you can handle very, very complex situations with quite a ease and precision. So this patient, you will see the image. And you will see that how he got treated. His ECG became stabilized. And this patient, look at the ECG. Immediately post, everything is settled.
Please conclude.
Yeah. So the last thing is, just about the FFR. Whenever there is a confusion, you can know which treatment strategy is right, whether angioplasty, bypass, or medical management. So to deal with very complex cases, there are certain tools. I will just discuss, this is a high pressure balloon. You can go up to very high pressure to crack the calcium, as high as 45. This is a balloon with blades. So there are blades which are there. And very, very interesting thing. Can you see this image on the right side? It is a pressure ultrasound lithotripsy balloon. Like we can break the stones in the kidneys with the lithotripsy balloon. Similarly, we can break the calcium inside the stone. And now I'll go to the last part. This is our atherectomy calcium breaking device, is about the Impella, which I did recently. I'll just show you what Impella is, because this is also an interesting patient. Just I'll take 30 seconds more. This patient was refused at multiple places. And because she was refused, well-preserved 85-year-old lady. Everybody said, very high risk, she will die on table, don't go for surgery. Biggest of the people saw her. The only thing was, because it was a left main critical, 25% EF and 100% RCS CTO. So either doctor refused or the patient refused after the discussion. So then we did something called as Impella. Now Impella is the world's smallest heart pump. And this is like a very simple pigtail catheter. This is my last slide only. So this is like a pigtail catheter where it goes inside, it takes over the function of the heart. Now once it takes over the function of the heart, you can do whatever you want. Once you open up the left main, because in this patient, if I balloon dilate the left main, that's the only supply. Right side is already 100% blocked. This patient would collapse and not give us time with a 25% EF. But everything happened very easily, and we could take out this pump on the table, and this patient is doing fine. Now this patient is planned for major surgery after 6 weeks, because there are certain stents where you can stop the antiplatelet after 1 month. So Onyx is one of the stents where, and there are a few other stents which have data where you can stop very early. So these recent advances and innovations have made complex high-risk situation to be dealt with precision and excellent outcomes. Untreatable conditions can be treated. Round-the-clock helps, and FFR is the right deciding strategy wherever there is a confusion that what is the best strategy. RDN is non-pharmacological treatment for high blood pressure, and structural cardiology is the most exciting field with rapid growth. Just to tell you the kind of work which we do at Apollo, I'm proctor for TAVI, TAVR, MICRA, OCT, IVUS, complex angioplasty, and Impella. And if you want to reach me, because I'll be leaving after this session, I have another session. This is my number. Thank you very much, and thank you, Educon, for inviting me for this wonderful conference. I can see on Sunday also it is so many people are still there. Thank you very much.
Thank you, Dr. Rahul. I invite our next speaker, Dr. Sewanti, to take this. While Dr. Vibhakar Advaryu, can I request you to please give a token of appreciation for our speaker, Dr. Rahul Gupta, who has made such an interesting presentation. So many difficult, hard situations also seem treatable when we listen to talks like this. Thank you so much for a wonderful talk on this Sunday afternoon. Our next speaker is Dr. SEWANTI LIMAYE. She will be telling us more about oncology and a personal way to treat oncology. Dr. SEWANTI LIMAYE. We welcome you, Dr. Sewanti. We are very happy to have you with us today.
Thank you. Thank you so much. I would like to just quickly introduce the topic as well as the speaker. That's myself. So I'm a medical oncologist with a slight nuance. I practice something called precision oncology, and I call myself a precision oncologist. In a few minutes, I'll explain what it exactly means. First of all, thank you so much for having me this afternoon. And it's a pleasure and an honor to be here. I'm here to talk about what is my lifetime's passion, and that is precision oncology, which is a specific way of practicing oncology where you try to understand the patient's tumor biology, and strategize the treatment based on that. So I feel that the future that we've talked about in oncology is now, and that's the man leaping. There should have been a woman, because then it would have been picture perfect. So essentially, I'm now at Sir H.N. Reliance Foundation Hospital. I used to be at Kokilaben for last 6 years. Prior to that, I was at Columbia University, a faculty there in New York, and prior to that in Harvard as a faculty. I did my fellowship from NYU, New York University, and residency from New York University and fellowship from Albert Einstein. And I can be found at this number, and this is my email, and these are my disclosures. I'm also a co-founder of 2 initiatives, one for-profit, ILON Precision Oncology, which is an effort in this direction. It's a for-profit concierge company, and then the Impact India International, which is a not-for-profit company, essentially to take big, difficult cases, deliberation into precision leaders across the country and also internationally. So why is this slide something that stands out to me every time I present? So if you look at the left upper corner, it's 1 in 2 men and 1 in 3 women will be touched by cancer in their lifetime. So this is an epidemic, this is a reality, and we heard great talks prior to me, and these were by surgeons, and I know my good friend Dr. Santoshi is also speaking after me, which is again, so it is largely, the onus is on surgeons to do the right job, but what is the reality at hand? 2/3 of the cancer worldwide today are diagnosed at late stages. So as much as we know that there has to be a lot of work done, and I'm working on some where early diagnosis is critical, and so we are devising ways to figure out cancer in blood, just by a blood test, and some of these tests are already in the market, some of them are coming. We have GRAIL launching the blood test, we have EasyCheck, TrueCheck 360 being launched by our own Indian company, Datar Genomics. So a lot is happening in the early diagnostic world, but the reality on ground for me as a medical oncologist, 2/3 of the cases are coming in late stages. So what do we do? I tend to choose to practice oncology in a way where I try and understand the biology of the disease better so that I can give right medicine to the right patient at the right cost, at the right time, every time. And precision is synonymous with personalizing therapy. This is an old concept. All doctors actually do a cross-match before transfusing. We look at the endocrine receptor before giving hormone therapy to breast cancer patients. We don't give hormone therapy to every patient. Having said that, this is a concept that took force in oncology with the discovery of the Philadelphia chromosome in chronic myeloid leukemia. This is a story that has been told a million times, where imatinib, the magic bullet, the drug, the oral drug that was given to chronic myeloid leukemia patients, elevated the survival from 20% to 90%. And the idea for precision oncology and personalizing therapy is to try and join everything, including targeted therapy, immunotherapy, all kinds, chemotherapy, everything to elevate the curve to 90% for all cancers. Is that far? Yes, it is. For now, it is. When was I touched with this concept? Very early on in my career. When I went in as a junior faculty at Dana-Farber, this is a picture of a patient, Ali Ali. Ali Ali was a runner. He was a patient with advanced recalcitrant oropharyngeal cancer. And when he came to me, we had a trial open. This is a Harvard patient. So we had a clinical trial open. In the clinical trial, this patient's front nodule, recurrent nodule, was biopsied. This patient had been through multitudinal treatment. And he had 1.5 years median survival, declared 1.5 years of median survival. At that time, in 2009, we had a trial running from National Cancer Institute in Harvard, one of the seminal trials in precision oncology, where we biopsied this nodule, and the nodule was then found to have HER2 amplification. HER2 amplification is seen in 20% of breast cancers. It's a routine targeted therapy treatment offered to breast cancer patients. It had arrived in breast cancer at that time, but not in head and neck cancer. This patient, once we figured out that he was HER2 amplified, he was given HER2-directed therapy. And why we could do that, because we had, this is actually my first publication as a junior faculty. This is in The Oncologist, where we studied HER2-directed treatment in salivary duct cancer. So I had just published this. And right around that time, this patient comes in and has HER2 amplification in a head and neck cancer. So we gave paclitaxel plus trastuzumab, and you can see the transformation. Just in 2 cycles, the disease went away. The patient continued trastuzumab for 2 years and then stopped it. This wasn't our recommendation. We don't stop HER2-directed therapy, even if the disease is completely wiped out. The disease never returned for him. So he remained completely in remission, and later on, Ali Ali was a runner, and he continued to survive despite his malignancy and continued to run marathons. I was also touched by the precision effort when moving forward to Columbia University. From Harvard, I came to, then as a faculty from Harvard, Dana-Farber, to Columbia University, where I was chosen to run one of the biggest, most ambitious precision trials run ever worldwide. It was called NCI Match Trial. NCI Match Trial had 40 arms. I wrote the Arm B. I was the national chair of the Arm B of this NCI Match Trial. This was open at multitudinal centers and treated nearly 40,000 patients. What did it contain of? You actually sequenced, you did genomic analysis of cancers and understood the pathways that were active in the patients and gave them drugs that matched their cancer. So I call cancer treatment this way a match game, and I have written about it in certain publications. So why is precision still not widely adopted? Mainly, I say this: when you have a pile and you've just organized the pile, right? Some of us have folded clothes. When you wash them and you put them in a pile, and then you figure out and you make them into piles for who's who, ye inka hai, wo unka hai, wo unka hai, you put them in piles. So once you organize that, that's how organ system-based therapy has been organized, right? Lung cancer ka ye treatment hoega, head neck ka ye hoega, gynecological malignancies ka ye hoga. Now I'm saying, bring them all together. Learn from this malignancy to that malignancy. Don't restrict yourself into malignancy organ silos. Understand the crosstalk between lung cancer pathways and breast cancer pathways. You just saw, I treated a patient with head and neck cancer with a breast cancer drug. So when you find the pathways, sometimes you don't know what to do with it. So you find the sock in the pile and you can actually wear it on your head, not knowing where does it go because you don't know what to do with it. So a lot of our information still needs to be understood better. People need to learn the science, understand the science, and that is why we are really still lagging behind. The application, it falls short because a lot of these pathways are tumor agnostic. It's like opening of a door in any malignancy. So if I had a sarcoma, I would sequence that patient, and if that patient had an NTERK fusion, we have an NTERK inhibitor. And there are many, many FDA-approved pathway-driven approvals of drugs that will be transformative for that stage 4 cancer patient as if they never had the disease. I also say one of the reasons why we have such trouble in understanding cancer, especially cancer that has metastasized, is because cancer is a 9-headed hydra. One head is suppressed, the other head will come up. Does that remind you of something? So at a very recent meeting, Dr. Vivek Subbiah, who is the leader of the experimental therapeutics at MD Anderson Cancer Center, actually presented this saying, is it Ravana's 10 heads? Is cancer Ravana's 10 heads? You hit one head, the other head comes up. You hit all the 10 heads, new heads come up. That's where the kind of science evolution is about understanding the tissue biology, the tumor biology. You have to try and understand the disease. So biopsy, histopathology, these are all standard of care. But genotyping and doing liquid biopsy to try and study the tissue, but also study the tissue evolution where the cancer sheds. Cancer sheds in the blood. And we can get the evolution, understanding of the evolution by doing sequential liquid biopsies. You can do longitudinal testing to understand what changed in that tumor and then attack likewise. Now moving over to some of the cases, if you look at lung cancer today, lung cancer is a poster child of precision oncology. Lung cancer is no longer squamous, small cell, non-small cell, adeno. No, you have these many classifications of lung cancer. Whether it be adenocarcinoma, whether it be squamous cell, there is a huge now genomic classification that we have to follow at medical oncologists. And pre-post images are abound. If we just see how EGFR-directed therapy in this patient, within 2 weeks, the lung opens up. This is stage 4 disease. ALK positive lung cancer. So when 2009, when I was a junior faculty, I had just joined, one of the biggest transformative applications I witnessed, 28-year-old coming in heavily pretreated, 7, 8 different kinds of chemotherapies already given. Patient about to die, brain metastasis, disease everywhere. Sequenced, found to have ALK, given ALK inhibitor. The trials were in phase 1. Phase 1, first in human trial, the disease transformed, poof, went away completely. And you can see this. If you see here, it's all light bulb, the entire light bulb is gone. This is one of my patients where you see a Christmas tree pattern. It's all clear. Everything gone by the time the patient reaches 2 years, continued. Now we are in a time where we understand resistant pathways will develop, and second, third generation drugs that are overcoming that resistance are also coming in. Breast cancer, we've talked about HER2-directed therapy. We have many, many HER2-directed treatments now. The drugs are in evolution. That pathway is actually so well understood, it has moved beyond the routine. When you look at breast cancer, inherited breast cancer, the patient could be BRCA positive. Now you have BRCA-directed treatment with a drug called olaparib. It's a pill. It's available in India. And these patients can be eligible. How do we not test for that? And many patients who come to me, they're young, 25, 35-year-old, multitudinal chemotherapies. Yesterday, a very senior and highly respected colleague of mine left a folder of a patient, said, can you please check this? This patient is in Medanta, Delhi. I looked over, the patient was getting treated by very, very eminent colleagues there. Last 3 years, the treatment has been ongoing. Patient presented at the age of 45. No BRCA testing done. So I think, now it's not just BRCA, it's also beyond BRCA. So we call BRCA-ness. We have to have a whole conglomerate of genes that are to be tested. So Now changing gears to the fifth modality of cancer treatment, which is immunotherapy and application of immunotherapy. Precision brings together everything. Precision is not about targeted treatment only. Precision is about personalizing treatment, whatever works for that patient. Chemosensitivity analysis, drug sensitivity analysis, targeted therapy, immunotherapy, even localized treatment that will enhance survival for that patient, like SBRT. I many times utilize transaortic radioembolization, the transarterial radioembolization, TARE, in liver cancers. So immunotherapy has also transformed a lot of our results. And when you see, it actually lifts the brake on our own immune cells. I say it's well tolerated because you have President Jimmy Carter as one of the previous examples. At 90, he got treated and cured of stage 4 melanoma that had gone to his brain with the help of pembrolizumab, which is one of the blockbuster drugs in immunotherapy. Then you have lung cancer cases, and again, you can see a Christmas tree pattern of metastasis for this patient, where I said the patient is going to die, had only a year to live. This patient responded only after 4 cycles of immunotherapy, transformative response. Even 7 years later, I looked this patient up on the Columbia Board of Trustees. You can still find him there. And again, few cycles of immunotherapy, the disease is completely gone. You have to have biomarkers. You have to figure out which patient is going to respond. That is most critical. So here we are looking at PD-L1 testing, which is done by immunohistochemistry.
2 minutes.
Here we are looking at tumor mutation burden, which is a genomic marker with which these patients respond. So in interest of time, I'll just go over some of the head and neck cases, 96-year-old, and you're just seeing pre-post. I'm not going to talk about it, pre-post. So light bulb on, light bulb off with immunotherapy. You see base of tongue tumor off with immunotherapy. Pictures were the 1,000-word, 1/4 of the face gone. This patient is surviving 5 years into presentation. Organ agnostic, where, like I said, precision can transcend pathways, no specific organ. This is MSI high tumors. This is a patient who is almost dead on her anniversary. This is a patient that I've treated where FOLFOX did not work for colorectal cancer. Patient was found to have high tumor mutation burden, treated, light bulb gone off with pembrolizumab. This is a gastric cancer patient, 18 nodules all over the broad body, very painful. Gastric cancer, you see here, earlier had breast cancer, cured, gastric cancer, 50 nodules, all of that completely cured, completing 2 years. Finally, the message that I would like to leave you with, it's about understanding the biomarkers. How do you understand them? How do you get your results? A lot of it I also do with reverse engineering. I do the testing in the lab to be able to conserve time because a lot of our patients are very sick. It's all about trying to understand the different parts of the elephant, and the blind man and the elephant has to work. People have to crosstalk. These are the drugs that have recently developed. We have to get out there, understand the biomarkers, and apply them. And I think we have to think beyond the routine. We have to look at the future, and the future is now. And we have to slay the Hydra. With that, thank you so much for your patient listening. I speak with a lot of passion, so hopefully I got some of the message across.
Thank you, Dr. Sewanti. It was such a wonderful talk. We really enjoyed listening to every part of it. Personalized precision oncology is something very new, different for us. Thank you so much.
So, I'm Dr. SANTOSHI NAGAONKAR. I'm director of urology, urological oncology, and robotic surgery at Sir H.N. Reliance Foundation Hospital. So, before I begin, I'll just give you a brief introduction. Basically, I got trained myself in urology from Mumbai, and then I practiced in Australia nearly for 12 years. In 2014, I came back to Reliance Hospital. That was my landing station in 2014, when the hospital actually was in its inception. I developed the urology department, the robotic department, and then I had to move back to Hinduja Hospital, which is my alma mater. I worked there for 6 years. And now I'm back again to HN Reliance Hospital, as I said, in the capacity of Director of Urology and Uro-Oncology. So Sewanti has made my life very easy because she has given the overview of the precision oncology. And now I'm going to talk about precision surgery. Probably you have already attended Dr. Ganesh Nagarajan's talk on the robotic surgery, which he mentioned about how precise the technology is. So I'm not going to get into that. He has already made my life easy. But what I'm going to do now is to go through certain things where the urologists, as urologist and robotic urological surgeon, how we are trying to push our limits to do the surgery. Now, as we know, humans they tend to push limits. And it's an ongoing, it's an evolving thing. We just need to know where to stop. If you know where to stop at the right time, it is fine. But can we really push our limits? And this dilemma has been going on for a long time. And do we have an answer for that? I don't think so as yet. So basically, know your limits, never stop. Trying to exceed them is always the goal. If you see these two gentlemen, these two geniuses, they have changed the entire scenario of the IT industry. Now, if these two were not there, our today's technology was totally, like it would have been far behind. Now, we don't know whether it is really a blessing, and some may argue that it may be a downside having so much of technology in our life. But is that true with the surgeons as well? Now, these four gentlemen, you may not have these faces familiar, but most of the urologists, well, they know it. I'll just run through them. The first one is the Professor Ralph Kleman. He's the first urologist to show the world that a kidney can be removed laparoscopically. Now, what I'm coming to is how they started pushing their limits. And you should know how they push their limits and how they succeed in what they aim for. So, Ralph Kleman was in 90s. Till then, the laparoscopy was applied only for laparoscopic appendectomy, laparoscopic tubal ligation, at the most laparoscopic cholecystectomy. Beyond that, there was no laparoscopy use. And this gentleman actually removed the kidney by means of a laparoscope. Our Professor Indy Gill, he's a product of Ames and now settled in the US. He's the chairman of University of Southern California, and he's been my robotic mentor as well. He actually pushed the limits further. Ralph Kleman had just done the laparoscopic nephrectomy, and in the Big Gill, he went ahead and did laparoscopic partial nephrectomy, where the renal tumors were small, so you don't need to remove the kidney. You just clamp the kidney and partially remove it, so you can preserve there is a substantial substance of the kidney so that patient doesn't have to go through any dialysis in future. So he pushed his limit. And he has still been pushing it by doing complex robotic surgery, so he's not stopped over there. Professor Pat Walsh is considered as the father of urology because he's the first guy who actually demonstrated the anatomical radical prostatectomy, which is for prostate cancer. Earlier, the prostate was removed just randomly for cancer, be it cancer or be it a benign disease. It used to be just get ripped out. But this gentleman actually showed that there is a sphincter, we have to preserve the sphincter, there are certain nerves around the prostate, and those have to be preserved. So he's pioneered the actual anatomical prostatectomy. Claude Abot from France, he's the first guy in 2000, year 2000, 22 years before this day. He demonstrated the first robotic radical prostatectomy, and that has revolutionized everything ever since then. And this guy, he's the game changer. Though Professor Claude, he demonstrated the first robotic prostatectomy, but our own Mani Menon, he's our Indian origin surgeon, he sat on the robot for hours together. The first robotic prostatectomy took him 8 hours, and he kept on pushing himself, and he demonstrated it to the world that robotic prostatectomy is the way to go. And if the prostate has to be removed for malignant cause, it has to be the robot. And in 22 years, in Western world, believe me, 99% of prostates are removed robotically. because it is widely available. The robotic systems are widely available, and it is cost effective. Now it has become cost effective way to deal with it. So this was his original robot, which was the first generation. Now we have come to the fourth generation of robot, more precise. Now this argument of pushing your limits has been there for several years. Initially, when laparoscopy had started, people were saying, and they were debating about what is the use of laparoscope, because I can do a better open job. Laparoscopy may have more complications. You may not be able to feel the tissue. You may have more bleeding. You may have more complications. You cannot see. Your assistant cannot assist you well. There were a lot of discussions going on. But that has settled now. Laparoscopy has been there for the last 40 years. The case has been rested. We know that laparoscopy has evolved, and it has been one of the best techniques which we can offer for certain surgeries. So nowadays, for gallbladder, appendix, you don't have to actually consider open surgery unless it is indicated. Same thing is going to happen with the robotic surgery. So what does the history say? So the first lap-assisted, as I mentioned, Ralph Kleman in 1991. Then lap-assisted partial nephrectomy, pushing the boundary. That's what I'm trying to say. Then the lap-assisted urological cancer surgeries, where the radical prostatectomy, cystectomies were done laparoscopically. And then Dr. Menon actually popularized the technique of robotic prostatectomy. Now, what are the hesitations one would have? So if I have done robotic prostatectomy, can I do anything further? Yes, you can go further ahead. You can do kidney removal robotically. If I'm doing kidney removal, what is the next? Partial kidney removal. If you're doing partial kidney removal, what is next? I can do a no-clamp partial kidney removal. What do you mean by no-clamp? So normally, if you just cut through the kidney, it will bleed like a hell. So you just clamp the kidney, the vascular supply is suspended for half an hour, you remove the tumor, and you sew it back. Once it is sewn back, you remove the clamp, the blood flow is restored. But people are now doing no clamp surgery, where you don't apply any clamp, kidney is perfused, and still you remove the tumor. So we are pushing our boundaries by doing complex retroperitoneal tumors and even adrenal tumors. Just like how Dr. Shewanti said about a person, Mr. Ali, who was a marathon runner, and he went through a really bad phase with his cancer, and then he was treated, and he was back to marathon. This is another gentleman. This story was published in The Week. It was the front page story. Mr. Ashok Joshi, he's now migrated to Pune, a marathon player, and he was diagnosed with prostate cancer. His first worry was, after going through the surgery or any kind of treatment, would I be able to run? And that is the beauty of robot. Though I had told him not to run for 6 weeks after the surgery, he started running after 3 weeks. And mind you, within 3 months, he was doing full marathon. Pandemic hit us. During the pandemic, he was so determined. He had migrated to Pune, and he had a big house. So he used to run half marathon in his house. So that's what the motivation comes from. And why I'm showing this? Because a robot has definite advantages, as Dr. Ganesh told you, that there is less bleeding, less scarring, less pain, early recovery. Patients can virtually go back to their working environment within weeks' time, few weeks' time. So I'm just going to run through some complex cases where we have pushed our limits in the last few years. Now, if you see, this is, I'm just checking the pointer. Pointer is not there. Okay. So this is the intraoperative case where there were 3 visible tumors on CT scan. This is a kidney specimen, intraoperative, and on CT scan it showed 3 tumors. So we decided to do robotic-assisted partial nephrectomy. There was no clamp applied, but as I went in, I had to use an ultrasound probe to check how the kidney is placed. And when I did the ultrasound, intraoperative ultrasound, I could find more tumors. So you can see, we actually managed to remove 7 tumors from this kidney. This is what I call pushing the limits, because had I known it before the surgery that patient has 7 tumors, I would have definitely thought, is he a good candidate for robotic, or will he be a good candidate for open surgery? But as we went in, we had the ultrasound, and it was much easier to remove these tumors without even clamping the kidney. This is another what you call your reward case or award case. This patient, 76-year-old gentleman, presented with right renal tumor. The tumor was going all the way into the inferior vena cava. The tumor was traveling through inferior vena cava up to liver. So it was a infrahepatic. Behind his liver, the tumor was extending. In ideal situations, such cases have to be done in open scenario. But there are many advantages of robotic because I could go under the liver with complete ease. Since the camera, the 3-dimensional vision, the 10 times magnification, all that makes it easy. If possible, I will run the video, but I'm not sure whether I would be able to do it. So you can see here, this is the side view. The entire thrombus is running all the way behind the liver. And what we did was a robotic. There were 6 ports, and the entire tumor was removed. This was level 2 thrombus.
2 minutes.
Yeah, I'll just be quick. This would have been the open incision for this patient. He ended up having 5 tiny scars and 1 scar for removal of the kidney. This is the video, but I couldn't run it. Now, pheochromocytoma, another thing. Open surgery, we can handle it better. We don't want to touch the tumor too much, but we can do it easily with robotic by pneumoperitoneum. This is the tumor which has been removed. Large tumor, you can see this is the kidney and the tumor. This lady, Cushing's syndrome, obese. Her weight was 170 kgs. Nobody was ready to touch her. The advantage, look at her size. And we just did the robotic adrenal tumor resection for the Cushing's syndrome. And on 10th day, she went home. Of course, she had a lot of post-operative issues like lung complications, but she was in the ICU. But from the surgical point of view, she recovered quite well. There was another young lady with hypertension. She had this is the right kidney, and there is a hilar tumor which was encircling the renal artery. Again, we were not sure whether we can save her kidney, but we could manage to save it robotically. She went home on the 3rd day. Retroperitoneal lymph node dissection, another challenging thing where you have to completely reflect the abdominal contents, go over the aorta and IVC and strip off all the lymph nodes. Can we do it robotically? Absolutely yes. And generally patients do extremely well. Within 2 days they go home. Look at the size of the incisions. For the first one, the open, and the second one is robotic. This is retrocaval ureter, again same way. Radical cystectomy, look at the size of the incision for open case. That is for the robotic. So again, how much to push our limits? Once we accept our limits, we have to go beyond them. This is another case which our department did in 2017, where they did robotic renal recipient transplant.
Please
Did you ever imagine this happening? No. So anyway, it's a newer technology, and the real limitations, it is not available in all centers. There is a learning curve. Acute emergencies, you cannot use it. Patient with severe kyphosis, you can't. Giant tumors and multi-organ involvement. And thank you very much for your patient listening. Thank you.
Thank you, Dr. Santoshi Nagaonkar, for such a wonderful insights on robotic urological surgery. While our next speaker, Dr. Prateet Samdani, comes on stage and takes up the topic of viral infections, may I please request Dr. Bharat Bhatt to give a token of appreciation. Dr. Bharat Bhatt, please give the token of appreciation for our wonderful Dr. Santoshi Nagaonkar on his extremely nice talk on robotic urological surgery. He has really shown us new techniques, new technology, and how we are going forward in the direction of urological diseases. Thank you so much for coming and being a part of Educon 2022.